and there is a big stone below it, and an stent it is migrated into the intrahepatic duct. So the first thing that I'm gonna do is to try to remove it with my balloon. So
So, good morning, everybody. Good morning, Michelle. Good morning, Thierry. So, this is how can you give us,
abajo.
for the people that are watching today now, how are the strategies that do you use during these kind of situations when there is a stent migration?
Yeah.
Thierry.
Uh, Good morning. Can you guys hear me?
Bájalo un poco.
Hello?
Yes.
But when
We can
there
hear
is
you.
stand migration, I'm using a snare.
Desinfla.
Okay, first of all, but I don't see the radioscopy. Can
Infla.
I see the radioscopy? I see
15.
the video, but I don't see.
Ya, cámbialo. Infla.
Can you repeat?
No, but just it is difficult for me to advise you because I don't see the fluoroscopy adequately.
Inyecta.
Okay, give me 1 second.
Okay. Yes, there are several possibilities. First one is to use, but you can use a large forceps. You can use a
Desinfla.
snare. You can use a dormier. You can use a balloon, but a long balloon for dilation along the stent. You can try to insert a guide wire in the stent and use a cylinder
Infla.
retriever. It depends it depends where is the distal part of the stent. If you,
So Juan
yes, you
Manuel
can use
is
such type of balloon, but this type of balloon is too small. It's
Desinfla.
better to use a long balloon for dilation.
Infla 18.
so
Infla 18.
Juan Manuel, what would you do? ¿Qué vas a hacer?
I think I will do. I wanna do a cholangioscopy to try to pass a guide wire into the stent, and then remove it with a maybe with a snare, because after that I need to perform a lithotripsy of that huge stone. So the idea is to be a little quicker if I can do the both things at the same way, at the same time. Sorry, but right now I trying again. Right now it's inflated the balloon to 18, but I can deflate. I can move.
But
I lose the stand because the colloidal is very large.
yeah,
Debe
I
ser.
know. That's why you need to use. If you want to use a balloon, you need to use a dilation balloon, a long balloon,
Yes, that's
not a
an
small.
option, but I think I will use a cholangioscope.
So he said that he will use a cholangioscope
Cholangioscope.
because he needs to do a lithotripsy. So in that kind of situation, yes, he can do it. Or do you prefer still to use the large balloon? Thierry,
Uh,
Michelle, what do you think?
Carlos, can you hear me?
Yes,
yes.
I can hear you.
So you need to. I think here Juan Manuel need to dilate the distal bile duct. This is a big common bile duct and common hepatic duct, but distally it's pretty tight. He's not going to be able to do anything unless he dilate. I agree with Thierry. He need to dilate that distal bile duct.
Okay, so we can do that movement now. It is very important to have your comments, the experts' comments, in this kind of situation, because this is no rare situation that happens every day during an ERCP. So we use a lot of stents to treat to broken big stones, and the migration of the stents sometimes happens, and this is a difficult situation for ERCP endoscopists.
Yes.
So what do you
But
think regarding using the stents before lithotripsy, or do you prefer to do to go inside and do a lithotripsy for big stones? What are your thoughts? Thierry first and then Michel.
I think personally, I think it's much better to remove a stent first, because of a stent, you will have a lot of air in the bile duct, and no, it will be difficult to inflate the bile duct with liquid. You need liquid. You need liquid to produce a shock wave. But in any case, you can try. But nevertheless, you have to remove a stent. So I would prefer to remove a stent first.
Yeah, but in normal situation, for example, in your practice, if you have a big stone, before to do a plastic stent, do you a plastic stent first and then an ERCP with cholangioscopy for lithotripsy or mechanical lithotripsy? Or do you prefer to do directly lithotripsy? What is the condition? What is your, your strategy when you have big stones? Do you use first, a stent, or what do you do? Not in this situation, not this case, just for discussion.
I'm an old guy, so first of all, maybe sometimes I've delayed the sphincter of Oddi, but I'm mainly using mechanical lithotripsy. Okay, in case it fails, I immediately use a spyglass. I immediately use a cholangioscopy to perform lithotripsy. So I never let a stone in place the first time. I always try to remove it by any means.
That's a good dilation.
Yes, but now if you delete, you need now. My advice is you go alongside. You insert the balloon deeper in the bile duct, along the stent, and then you along the stent at more or less, yes, but deflate first, deflate, because then you will push the stent. Deflate, you go up along the stent.
Yeah, you need to deflate the balloon.
You should deflate the balloon. Okay. You should deflate the balloon, and then you reinflate, and then you try to remove the balloon plus the stent.
No se viene, desinfla. Es que no logro pasarlo. Desinfla y quítalo en presión negativa.
So I think this biliary tract is very dilated. I don't believe that with the balloon, with this strategy, we'll arrive to remove the stent.
Try it. But inflate the balloon.
I mean,
at the distance, at proximal, at the upper part of the stent, no? Yes.
I mean, if you can at least bring it down, you can then grab it with the Ratus forceps.
Yes, for example.
Otro poco más.
Try, you will see. Turn on the right, and you push. Yes. Turn on right, yes.
The stent is coming, I believe. No, no, it was not the
pull.
stent.
Desinfla.
So,
Desinfla.
No, the balloon
So-
is maybe not so large.
yeah, we delayed until 13 or 14, 15.
13.5.
¿Cuánto?
3.5.
12.5. So I believe we will take more time, more fluoroscopy. So I suggest to change the strategy. We need to do a lithotripsy, so it's better to use a cholangioscope and treat to remove the stent. What I will do suggest is to put to less there the stent and then go inside with a cholangioscope. What do you think, Michel?
Yeah, I think it's going to be a lot of traffic. I really, the stent is not too far inside. You can actually see the tip of it. I would actually try at least for like 5 minutes to retrieve it with the Ratus forceps.
Okay.
Exactly.
It's really
I agree.
close.
I agree. And you push on the right tooth to make a curve. You have to make a curve and to arrive more or less perpendicular to the stent, or at least
Yeah, and you can
45
see-
degrees.
And you can see the position with the X-ray of the Ratus.
Yes. Yes.
So, okay, we will do your suggestion with the rat tooth.
More,
Otherwise, it's
frankly
going to be too
speaking,
much traffic.
Carlos, frankly speaking,
Yes.
it's more interesting to see extraction of a stent than to see the lithotripsy, which is quite
Yeah,
common.
totally agree. So we are doing different strategies to retrieve to taking off the stent from the biliary tract. So that's it. We are doing all the strategies now.
Abre. Cierra.
Open, close,
No, abre.
open again,
Yeah.
Cierra.
close,
Abre.
once again open, turn, turn it,
Cierra.
close,
Almost.
Abre. Abre, abre, abre.
open, open,
Cierra. Se suelta.
close,
Abre.
open,
Cierra.
close,
Foto.
still, take a picture there,
Oh,
Oh, very good.
This is beautiful.
Abre. Muy
open.
bien, voy a salir con todo, ¿ok?
Now I'm going to remove everything.
Very good.
That's beautiful.
Abre.
So there's a question from the audience. When do you use the basket. Is the basket a good option in this kind of cases?
In this case, is the basket is gonna be a little bit more difficult because the bulldog is really big. The basket is great when your bulldog is smaller and you can go over the wire and literally take the stents, into the wire. Then the basket works. In this case, the bulldog is really big. You really need something to bring it down. And I like what Thierry said. Bring it down with the balloon and then extract it with the rat tooth.
So any other comment regarding your strategies? So
No.
just
No, no.
just
Sometimes when the stent is short, you can use a snare or you can use the basket and you take the upper part. You pass through the upper part and you go down along the stent with the basket open or the snare open. It also when the stent is short.
so today we will show a new colonoscope. This is from Microtech. This is 11 French colonoscope with a working channel of 1.8 millimeter. So it's a large working channel colonoscope. So it's a high definition colonoscope.
Is it commercially available in Ecuador or South America or
Yes, now is
USA?
they are doing the registers. So we are starting a protocol to see um, the safety and efficacy of this new product. And the interesting is that they are working with a company that perform EHL, that they have a bigger lithotriptor, so that works with this working channel, so have more power in cases of big stones or difficult stones.
Sígueme empujando.
Levanta la uña.
Está toda.
Lift it up.
And you have two bendings. You have two. How many bending? You have one, two, or two?
Two banding. Mete agua.
Insert water, please.
Ahí.
So if I observe, you try to insert without a guide
Yes.
wire, huh?
He's inside now.
Okay.
So the quality of image is not bad. You can have also a white balance, like a normal scope, and you can have different features of the colonoscope, as you can see here. Different shapes when you are looking. It's very interesting. So it remembers all the kind of image that we had before with different scopes, Pentax or Fuji, at the large of the history. So the lithotriptor that we will use is a Germany company. The name is Walls. It's available in Europe, CE markets, and in Ecuador is now available. It's
Electrohydraulic.
yeah, it's a EHL, electrohydraulic lithotriptor, but have more power. What kind of probe you will use now?
I am using the 4.5 probe with a power. B power is a medium power. ¿Puedes pasar o no? Deja ir hacia arriba, ok.
Can
Sí, subí.
can we pass? No, turn it upwards.
Todavía no.
me see.
Pásame la
Which
otra, por
screen? You have a specific screen for this cholangioscope?
Excuse me, Thierry.
You have a specific screen, a specific, yeah, monitor. Which monitor do you use? Which screen
No,
you use?
the standard one. The standard
The
one.
standard one.
We have, yeah,
Okay.
high definition standard one. We are using an NDS Radiance HD Ultra here, but
Okay.
you can use a standard monitor. So, how do you see the quality of image? Sorry.
Satisfactory.
Yeah, no, it's a good quality.
Satisfactory.
So I think this this and next year it will come in new cholangioscopes, more
Yes,
companies.
and
I believe
one
that the
detail.
price of cholangioscopes will going down, and more,
Yeah.
more people can use more and more the cholangioscope. What do you think regarding the future of cholangioscopy? Thierry first, and
Well,
then
first of
Michel.
all, I'm a big supporter of colongioscopy since years, because in the past I performed a lot of percutaneous cholangioscopy. Then I tried to perform retrograde, but the material, as you know, was fragile. So we were waiting for a, if possible, not so expensive single-use cholangioscope. So I'm quite satisfied. I think there are not so
So
many indications, but
yeah.
for sure it's definitively a very interesting procedure.
So you see, this is the tip of the probe is bigger,
Yes.
so you can put more power if you want. It's really
C. Allá, C.
One important point:
No,
do you touch the stone, or do you stay just at 1 or
no
2 millimeter?
puede, está seteado.
no. You have not to touch the stone.
No,
You need to
you
be
need to be
Yes.
5 millimeter.
5 or 6 millimeters away from the
Okay.
stone.
Perfect.
So the stone is broken.
So one question is that who is manipulating the cholangioscope?
Juan Manuel.
Ah, yes. So you can such as a spyglass, you can
Single,
manipulate
yes.
yourself.
Single operator.
Does it also connect to a water pump?
Yes. Acércate un poco más.
Please come closer.
It's
It's a
very,
big
very big
stone.
stone. So
Well,
one of the predictive factors that we saw in our series, in our retrospective series in our institution, is that big stones more than 2 centimeters and also multiple stones are risk factors to have second cholangioscopy or lithotripsy. What do you think about that, Thierry and Michelle, in your experience?
yes, yes, I agree. The risk of recurrence when you have a large stone is, of course, higher, no problem. And but you don't know exactly which for which reason. Probably the bile duct is very dilated. Probably there is some problem related to the peristaltism in the duodenum. But when you have a large stone, it means you have a large duct, and then you have a risk of recurrence. And this stone looks more It looks not cholesterol, huh? It is bilirubin.
I mean, the other problem with stone disease is you have to make sure that you've treated all the disease of the bile duct. Like if the patient has a biliary stricture, you got to treat that aggressively. Otherwise, the stone will recur.
Yeah. So, what are your indications after you clean a biliary tract? And do you use medication for prevention, diet for the patients?
I mean, you can give them Actigal, but really the most important thing is to make sure that there's zero resistance to a balloon sweep. And if I feel any resistance, I'm very aggressive with stenting.
Yes, but you are right. But frankly speaking, in some cases, not so frequent, you have multiple recurrence. Okay, and you don't know for which reason. Bile duct is large, the peristaltis duodenum is not so good, etc. And so at the end, sometimes you are obliged to go to surgery to perform an anastomosis. But it happens rarely. But there is no clear explanation why it does recur. And the patient comes back every 2 or 3 months with large stone. How many stones initially the patient had? I don't remember. One?
One bigger, one bigger
So
than
one
20
also
minutes.
you should also take care is that the patient had a cholecystectomy before or not? Yes. Because sometimes when you see such large stone, if a patient has a gallbladder in place, you can have a fistula between the gallbladder and the common bile duct. And so then it's of course necessary to treat and to remove a gallbladder. It because such large stone we don't now in France we see rarely such large stone because the patient they had surgery very rapidly in case of gallbladder stones. In the past, I saw a lot of cases, and such cases were related to a fistula between the gallbladder and the common bile duct, and the stones were quite large. But this case, more or less, have disappeared.
Yeah. I believe this patient, when he have his surgery, 30 years ago, 20 years ago, many years ago. So more than 20 years ago at least. So probably um, this is in Ecuador. We have a lot of patients with this kind of stones, big stones, sending to us to do lithotripsy because the time. So for the moment, I will let Juan Manuel working here, continue working with the stones, and I will move to the another room to see the next